grade. Some of them where the soft tissue sarcoma, just based on the histology itself, the differentiation D, N, and M, as we talked about it, the differentiation node and metastasis as the thing which is important. It is not just the stage of the sarcoma. In grading, you have to talk about the differentiation, which is equally important. Just a sec, let me get my pencil plugged in. Sorry, some technology issues basically. So anyway, we talked about the D, N, and M, where D stands for differentiation, N for the necrosis, and M for the mitosis. So all these will be the features that will be taken into consideration. But the important factor is going to be differentiation, where we saw that Ewing sarcoma, PNET, extraskeletal osteosarcoma, synovial sarcoma, all of them will be always considered to be a high-grade sarcoma, whereas the others will depend on the type of differentiation. And we also saw the French system, the FNCLCC, that is the Trojani system, which is the most important system that will be predictive of the prognosis as far as soft tissue sarcoma grading is concerned. And once we have seen all that, then we spoke about the role of radiation, how whenever we are planning for radiation in a high-grade sarcoma, we talked about, just to give a brief primer, this was the tabular column where we discussed it, where we said that, the presence of any high-grade tumor, and especially some of the chemosensitive sarcomas, we have to consider going in for preoperative chemotherapy, which usually includes the embryonal types and the Ewing sarcoma, those kind of tumors, where you'll go for preoperative chemo. Select cases of synovial sarcoma also, you can consider chemotherapy, but usually it applies to Ewing's, osteosarcoma, rhabdomyosarcoma, and some of the myxoid and round cell type of pleomorphic liposarcomas that we will have. So these are the types where we'll consider going in for preoperative chemotherapy. And the role of radiation, which can be avoided in case you have a low-grade sarcoma, basically a stage 1 sarcoma, which is completely excised. There is no role for adjuvant therapy. Most other sarcomas will require, except in cases where it's a high-grade sarcoma, but it is less than or equal to 5 centimeter and completely excised, we can avoid the radiation therapy. All other cases will need radiation. And whenever radiation therapy is needed, it is preferable to go for a neoadjuvant radiation therapy. Why? Because we already saw that whenever we talk about neoadjuvant radiation therapy, it is going to have an intact blood supply and good oxygenation. All these are going to be the features that are present. So in such cases, you will prefer to go for neoadjuvant radiation therapy, which will be the method of choice. Now, going on to the type of excision that we have in a sarcoma. Now, when we talk about the type of excision that we have in a sarcoma, there are 3 types of excision. Now, if you look at the yellow structure here, what is shaded yellow here, or now which I have shaded as red, that is the main tumor. Around this tumor, usually there will be a zone of tissue, that purple zone which is seen, which is known as basically what you can call as the reactive zone. Now, this reactive zone of pseudocapsule, otherwise called as the pseudocapsule. Now, this is a tissue which is formed by the surrounding, reaction of thickened tissue, but it will have tumor cells inside it. Now, whenever we are having this, excision within the level of the pseudocapsule, we call it as an intralesional or a marginal excision. So, when you have it within the pseudocapsule, you call it as an intralesional excision. Just outside the pseudocapsule, you call it as a marginal excision. So, in a sense, you have a tumor which is going to be like this. Then you have another zone of tissue. This green line will represent the pseudocapsule area. Now, whenever you're planning for an excision, you will have, if you excise the tumor here, that will be known as an intralesional excision. If you go through this plane just around this area, just around the pseudocapsule, that is known as a marginal excision. Now, what do you mean by wide excision, which should be done for all patients? That should be around the pseudocapsule. So you go for a good 1 centimeter margin around the pseudocapsule 3-dimensionally, and then you take it. So if you look at it, the red zone here is going to represent the area of your tumor. Now, anything which is done within the red zone, as this orange shaded area here, which is given, that is going to be your intralesional excision. The green zone is the pseudocapsule, and the black line which you represent is in and around the pseudocapsule. We are not sure of where we are going. Usually, it appears to be an area of compressed tissue. So it will be tempting to go in that plane and take it out, but it will be like shelling out the tumor rather than removing the tumor completely, because inside this area, now inside this particular area, you will have lots of tumor cells. The dots which I'm putting inside the pseudocapsule area, those will be the tumor cells. And that is the reason why you always have to go in the mark line of pink. Around 1 centimeter should be the margin that you give here. So 3-dimensionally, you go for a 1 centimeter margin and then you take it out. That is known as a wide excision. Now, the preferred minimal resection that you have to do for any kind of sarcoma is going to be a wide excision. Now, the margins for sarcoma are traditionally considered to be around 1 centimeter. You have certain tumors like DFSP, for example, where you'll have to plan for at least 2 centimeters, where you'll have to plan for at least a 2 centimeter margin. So except for a few sarcomas, mostly 1 centimeter margin will be good enough. And then you have the concept of radical resection, which used to be there previously. So any soft tissue sarcoma, the treatment used to be an amputation of the limb. Currently, we know it is not needed. And again, radical resection is something similar, where we plan for the entire compartment. All the muscles are removed from origin till insertion. Now, this kind of thing is also not currently recommended. What we need is only a wide excision of the tumor. That is the margin negative clearance that we need as far as management of sarcomas is going to be concerned. So, as I said, it should be 1 to 2 centimeters beyond the pseudocapsule of the excision. Now, there is another question that comes commonly. We had a discussion even last time. So, whenever we have a margin positive resection, the question comes, if there is a margin positive resection, and if you get the option, one of the options is re-excision, then that should be the option that should be marked. Okay. Now, the problem with re-excision is a lot of times you may not know which area is going to have the tumor or which margin is the positive margin. That if the original surgeon had tagged the specimen and they have sent it, then they will know. Otherwise, sometimes what happens is, let me show it for you. Let's, for example, assume that there is a tumor which has been excised here. This red line is the scar that you have. Now, we just know that the tumor has been excised and they have mentioned it as focal margin positive. We don't know which margin is positive. Suppose they have mentioned if the specimen has been tagged and sent and, superior is positive, lateral is positive, medial segment is positive, or inferior or deep is positive, you can go and excise that area alone. If you don't know which area and you just have the scar, then you can go and excise circumferentially around the scar. In many places in cancer centers, what they actually do is they prefer to go for re-excision of the scar when it has been an unplanned excision. In any unplanned excision, whenever you have an unplanned excision, it is better to plan for re-excision of the scar. Now, re-excision in this cases, in almost 30% of cases, you will still find residual tumor. In 30% of cases, still you will find residual tumor. And that is why it is mentioned that it is better to plan for, whenever there is an unplanned resection, to plan for a re-excision of the scar. And the same thing will apply whenever you have a margin positive resection as well. So the correct modality of treatment for all these tumors is going to be a re-excision. The correct modality of tumors for all these tumors is going to be a re-excision rather than leaving it alone. You will always plan for a re-excision of a margin positive resection. Now, what is the chance of metastasis? We know that in high-grade sarcomas, the metastasis-free survival is around 43%. The most common metastasis usually happen to the lungs. The most common metastasis usually happens to the lungs. The most common metastasis usually happens to the lung. 19% of cases, it will be lung metastasis that will commonly happen. It will be lung metastasis that will be commonly present. Okay. So always, whenever you're planning for a staging, you need a CT of the chest. So we talk about local imaging in the form of an MRI most likely. In all cases, we'll plan for an MRI of the local part. Along with that, you have to plan for a CT of the chest to rule out the presence of distal metastasis. Right. Now, going on to the next specific type of sarcoma, we already saw regarding our liposarcoma. Now going on to the second type of sarcoma, which is your leiomyosarcoma, which is the false statement here regarding leiomyosarcoma. Now, if you look at it, this is the second most common type of STS. So this is the second most common type of STS, most commonly happens in the uterus. Management is mainly surgical. All of this is predominantly true, but the role of adjuvant RT is debated. The role of adjuvant RT is not well known. It has been tried, but so far there is no gross evidence for saying that you have to go for adjuvant radiation therapy. Now, in leiomyosarcomas, most common in the retroperitoneum and intra-abdominal. So intra-abdominal, when you talk about it, whenever you talk about intra-abdominal, so there is a thing for saying that most common intra-abdominal sarcoma is actually a uterine LMS. Okay, it's one of the most common intra-abdominal sarcomas. The important site where this happens is going to be in the uterus. LMS overall, that is leiomyosarcoma, is the second most common STS after liposarcoma. So lipo is the first, and then you have your leiomyosarcoma. So leiomyosarcoma is the second most common STS. And then if you look at it, what are the other subsites where it can happen? It can also happen in the IVC. This is a specific type of leiomyosarcoma which will engulf the whole IVC, meaning IVC will be completely replaced by the tumor, especially common in the infrarenal segment. And in case you have got a lot of collaterals that are formed, many cases, even though it is blocked, you will not find that there is any gross edema or anything like that of the limbs. What you will find is the collaterals would have formed and they would have taken over the function. So if you can ligate and remove the tumor, sparing the collaterals, then this itself will be enough. This one without reconstruction, then there is no need for reconstruction. Now we all know, otherwise we need to plan for a reconstruction. But in case the collaterals are good and you can spare the collaterals, then you can resect it completely without having any kind of reconstruction. So you have a tumor. You have the IVC, and then you have the iliac vessels which are going to be there. Let's say the tumor is going to be in this particular area, and you already have the collaterals which have formed from here to here. Like this, multiple collateral channels are there. In case you can plan for an excision, you can just remove this with wide margins, completely remove it, and you can ligate both these ends together. Okay, so you can just basically ligate off this edge and ligate off this edge, preserving the collaterals. So as long as the collaterals are preserved, you can do just ligation alone without reconstruction. In case the collaterals are going to be ligated, in such cases where the collaterals are going to be removed, where the collaterals cannot be spared, that is a kind of scenario because of margins and all that. In such scenarios, you will have to do a graft. So there, suppose you have a tumor like this and you have resected that area. In between, you will have to put a graft like this. Okay, so in between, you have to put a graft like this and you have to reconstruct it. And suppose the renal vessels are there, they have to be reimplanted. It can be a pretty major undertaking, but there are cases where we have done it also. So retroperitoneal sarcomas, especially the management is going to be somewhat tricky. You have to be prepared for major resections and reconstruction as well, and involves a lot of planning. The imaging is very, very important. Like in any major cancer surgery, the imaging is going to be of vital importance. We have to go through the imaging properly and plan for the surgery. Now, as far as adjuvant therapy is concerned, here I have mentioned, you see, uterine LMS, the main treatment is going to be TH and BSO. That's it. So is there a role for any adjuvant therapy? So far, nothing. There is no definitive adjuvant therapy as far as LMS is concerned. Now, there is one particular drug which is known as olaratumab. Now, this drug is an anti-PDGFR agent. It's a monoclonal antibody against the PDGFR. Now, this particular agent called olaratumab is used in advanced unresectable STS, especially in leiomyosarcoma. This is based on Subiston. In DeVita and all, I couldn't really find the reference. It's not commonly used in oncology as far as I know, but it is given in Subiston, so it may come as an MCQ point for you. So olaratumab is a drug which may be used in advanced unresectable STS, especially in leiomyosarcoma. The next type of sarcoma that we are going to talk about is, or a sarcoma-like lesion, is going to be your desmoid tumor. Now, in desmoid tumor, if you look at it, the desmoid tumors, which is the false statement, most desmoids are associated with FAP, constitute the second leading cause of death in patients with FAP. FAP-associated desmoids have high recurrence rates despite adequate resection. Active surveillance in imatinib are options of management due to the indolent growth pattern. Now, which is the false statement here? I will let you leave this part, second or third, whichever is given, unless it is asked in a sequence, you can just take it that will be the true statement. Now, regarding desmoid, it's mentioned here, most are associated with FAP. Second leading cause of death, yes, this you can take it as true. Don't confuse with third. That is okay. Second or third is okay. And FAP associated desmoids have a higher recurrence rate despite adequate resection. This is also true. Active surveillance in imatinib. Contrary to what we think, not all desmoids need a surgical resection. We can just observe by active surveillance, especially if it's near, some of the things where you may not get a clearance and all that, you may just do an active surveillance, put them on imatinib, and only when it grows bigger, you can consider resection. So the answer is most of the desmoids are actually sporadic. Okay, so most of the desmoids are actually sporadic. Almost 70 to 80% of desmoids are going to be sporadic. Only 20-25% are associated with your FAP. So in these cases, polyposis occurs first. So polyposis happens, the patient undergoes a colectomy, and usually it happens at the scar site of the prior colectomy. That is the most common site. If you look at it, it's the most common site is going to be at the site of the surgical scar. Now, on the other hand, you also have to remember that intra-abdominal desmoids are more common in FAP. The question may be worded differently. They may ask, which is the most common site of desmoid in FAP? The most common site is going to be in the surgical scar. But that said, when you look at it, desmoids usually happen in the skin and in the subcutaneous tissues. In your FAP, intra-abdominal desmoids can also happen. Intra-abdominal desmoids can also happen commonly. And both of them are associated with the beta-catenin mutation, CTNNB1 mutation. So both the sporadic and the FAP desmoids are associated with the beta-catenin pathway, that is the CTNNB1 mutations. So they are the second leading cause of death. Second or third depends on the series that you take. I already told you some time back that you can take it as either duodenal or this one. Both of them will be close to each other. Okay. So FAP desmoids have a higher recurrence rate. This is one point where they differ a little from your sporadic desmoids, in that even if you do an adequate margins you give and then you set them, still they will have a higher recurrence rate. And because of this reason, active surveillance and imatinib are also options in management for such patients where indolent growth, right? So you can wait for it to become a little bigger and then you can take it, and you can put them on other agents like sunitinib, like salindac, not sunitinib, sorry, like imatinib, like salindac. So these lines of medical management, celecoxib. So these are some agents which are available, which can be given for, basically keeping the desmoids under control. All these COX inhibitors, your aspirin has been tried, salindac has been tried, celecoxib has been tried, imatinib is one of the agents. All these have been agents which have been used in the managements of desmoid by a medical management. The next sarcoma that we are going to talk about is angiosarcoma, which is the false statement here. The most common site is the scalp. Risk factors include lymphedema, radiation, and thoratrast. Resection with margin of 2 cm is recommended, and IHC for CD31 and FLI1 is positive. The answer here is the most common site is actually the trunk. Okay, so angiosarcomas usually happen in the trunk. Okay, so when you look at it, the most common site is trunk. The second most common is head and neck. In the head and neck, the scalp is the most common site. So it is trunk greater than scalp. Okay, so scalp is the second most common site. Trunk is the most common site. In the head and neck areas, when it happens, scalp is the most common site. We already know about the lymphedema-associated sarcoma, which is known as your Stewart-Reeve syndrome, happens outside the field of radiation. And radiation-associated sarcoma, this is one of the common sarcomas. So I already told you, RT as a cause of sarcoma, the first choice which I would mark, the most common, if I will say, is going to be your undifferentiated pleomorphic sarcoma. Second most, if that is not given in the option, then you mark it as angiosarcoma. Okay, these are two very common cancers which are associated with radiation. So this is one of the sarcomas where a 2 centimeter margin is recommended. Even 2 centimeters may not be enough, because we have had patients where we gave a good 3 centimeter gross clearance, and then you could find microscopic foci extending beyond that also. So as wide a margin as possible is what is recommended in angiosarcoma, but at least 2 centimeter minimum you will plan in angiosarcoma, in DFSP, all these cases you will plan for at least a 2 centimeter margin. So scalp is the most common site in the head and neck, and you have this FLI1 and CD31, both of which will be positive IHCs as far as your angiosarcomas are concerned. And most common metastasis, as we all know, happens to the lung, where hemothorax can happen. Okay, so where you can have a hemopneumothorax extensive, this one tendency to bleed will lead on to a hemopneumothorax. which will happen in your angiosarcomas. Right. Next one is about the DFSP. So in DFSP, we have, which is the false statement, T1122 translocation. Then you have the call1 with PDGFR. Both of these two are going to come to each other. Then you have sensitivity to imatinib intersection with 2 centimeters. Now we all know about, some of the things already here. Imatinib is used in treatment, all of us know. We all know that there is a 2 centimeter margin. We have discussed this 2-3 times. And this is the characteristic mutation. It is not T1122, it's a T1722 translocation. Okay, this is one of the translocations you have to be aware of. And there you have the collagen with PDGFR combination. You have the collagen gene, which is going to be, kind of juxtaposed or brought close to the PDGFR gene. Both of these, when they come together, that leads to the development of this particular, intermediate grade sarcoma. And that is the reason, because of the PDGFR is why it is sensitive to imatinib as well. Imatinib is used in the management of these patients. This 1122 translocation, as we all know, will happen in your Ewing sarcoma. It happens in the various forms of the most common mutation or translocation, in Ewing sarcoma is going to be the 1122 translocation. So if you look at it, other types of this one, let's talk about DFSC first. As I said, 1722 translocation, fusion of call1 with your PDGFR beta, and that is why it is sensitive to imatinib. Trunk is the most common site, just like angiosarcoma. Trunk is the most common site. It can also happen in the extremities. Again, there are questions that have asked for 2 centimeters, 3 centimeters, but most books mention that at least 2 centimeters, including your NCCN also mention at least 2 centimeter margin should be given. So in your exams, I believe the answer should be 2 centimeter as far as the margin is mentioned for your DFSP. And then you have your dermal or subdermal. The location, it will come under the cutaneous tumors as well. This will come under the cutaneous tumors as well. It is an indolent tumor, but it has got a high tumor recurrence rate. It is an indolent tumor, but it will have a high tumor recurrence rate, and the margins need to be very, very wide. So there have been questions where they say DFSP has been operated. The margin given is 1 centimeter, margin is free. What will be the options of management? In this scenario, it is preferable to go and re-excise the tumor. Okay, even though the margin is negative, there is a high chance of recurrence. So better to go and re-excise the margin. This is one scenario where the option should be re-excision. Radiation per se does not have a big role. Okay, margin positive or places where you cannot achieve a margin. That's a very rare scenario. Usually it will happen in the skin and subcutaneous tissue. So excising the lesion is not usually a problem. So in such cases, the option in DFSP, even though the margin is clear, anything margin is less than 2 centimeters, they have mentioned, then the better option is to re-excise the tumor. It is go for re-excision of the scar, basically, as we discussed. That should be the management. That has come as a question in a couple of examinations. So the other tumor, previously what was known as your MFH or malignant fibrous histiocytoma, currently it is known as your UPS or undifferentiated pleomorphic sarcoma. Previously the most common type. Now because of all your genetic studies and molecular studies, we know that most of these, almost 2/3, have been reclassified into other types, and now this is no longer the most common types. That said, UPS is still one of the most common radiation-induced sarcoma. If you talk about radiation-induced sarcoma, MFH is going to be in the top list here. Then you have NF1 associated sarcoma, which is your MPNST, which is basically your neurofibrosarcoma. Right. Now, when we talk about other locations of sarcoma, we have to talk about your retroperitoneal and your visceral sarcomas. Now, in your retroperitoneal and visceral sarcomas, most common is going to be again liposarcoma as far as the retroperitoneum is concerned. Now, intra-abdominal, as we already discussed, the most common is going to be your LMS. Okay, LMS is going to be one of the most common intra-abdominal sarcomas, both GIST and LMS. Now, which of these two is the most common is open to debate. But if they ask you which is the most common intraperitoneal, I will probably mark it as LMS, which is more common than GIST. But that said, now more GISTs are getting diagnosed at a smaller stage because of increased imaging and all. So it is a toss-up between the two. So if both are given, I'm not sure. Probably I will mark LMS because uterine sarcomas are more common as compared to GIST. So overall, I would tend to mark in intraperitoneal soft tissue sarcomas, the answer should be LMS. Okay. Now, in the retroperitoneum, we all know that it is going to be liposarcoma, and then you have your LMS, which is the second most common. Now, for your retroperitoneal sarcomas, as I already said, contrast enhanced CT. CT is going to be the investigation of choice. Here, the soft tissue delineation is not very important. the same degree of delineation can be usually obtained compared to the extremities in the retroperitoneum. You will get a good imaging with CECT abdomen itself, and there is going to be less imaging artifacts because patients cannot lie down for a long time with a tumor which is sitting in the retroperitoneum large and pressing on vital structures and all that. So MRI gives a better soft tissue delineation, but imaging is, the image acquisition is faster, less artifact. So generally the preferred modality for imaging is going to be a CCT of the abdomen and pelvis area. Now, preoperative biopsy, this is a controversial thing, whether you need to do it as a routine when you strongly suspect that there's going to be lymphoma, germ cell tumor, or metastasis or something like that. In such cases, it is better to do a biopsy. On the other hand, if it is clearly a retroperitoneal sarcoma, then you can avoid it. That said, there are authorities who say better to do a preoperative biopsy because if it is something which is chemosensitive, then we can plan for a neoadjuvant chemotherapy. So some authorities prefer to do a biopsy in all cases. But that said, if it is a clear-cut tumor, imaging shows it to be likely to be a liposarcoma. In such cases, you can plan for a resection. The management, again, is a complete gross resection. All you can achieve in such tumors is only a complete gross resection. Margin assessment is kind of like not possible. It will be too huge a tumor. Somewhere the margin is likely to be positive. So grossly, you achieve a R0 resection. That is the only thing you can do. It is likely to be microscopically positive. Now, one thing which is happening in recent times is neoadjuvant radiation therapy. Whether we can give neoadjuvant radiation, the picture on the screen is depicting of that. There is a sarcoma, there is an IVC sarcoma, which you can see here. You can see the IVC which is pushed up here, and you can see the growth which is hanging down from the posterior aspect of it. You can see that there. And this one, now after giving radiation, it has become completely kind of like, devoid of tissue. So that kind of good response is sometimes seen with the neoadjuvant radiation. So that is being evaluated in the management, right? Now, the next type is going to be your GIST or gastrointestinal stromal tumor, which I think Dr. Rajamendran would have taught. I'm just going to touch upon it. So, which is the false statement here? Wide excision with 1 centimeter margin is the standard for gastric GIST. Syndromic involvement is seen with Carney-Strategy syndrome, germline EDH, NF1, von Hippel-Lindau disease, and all that. And we all know about the CKIT and CD117 and the DOG1 being positive. So dasatinib has a better response in patients with imatinib resistance GIST and PDGFR D842 mutations. So which is the false statement here? The answer to this question is there is no need for any big margins as far as GIST is concerned. It only needs a gross margin negative resection. So you don't need to go for big margins, especially in areas where, for example, you have a tumor which is sitting near the GE junction. So there you don't need to go and take out the esophagus. You can just resect it like this and you can come, provided you get a negative margin. You should not leave behind tumor. It should only be a negative margin. There is no role for lymphadenectomy also because lymph node metastases are almost unheard of as far as GIST is concerned. Now, which is the cell of origin? It is, okay, so among the viscera, this is the most common visceral STS, okay. So among the viscera, this is the most common thing, right? So maybe I think you should mark GIST as the answer as far as the exams are concerned. I'm reversing my earlier statement because this is one term which is mentioned, most common visceral STS. So intra-abdominal is where you will get your viscera. So maybe you can mark your GIST as the answer when it is asked as most common intra-abdominal sarcoma. If they ask you, then you can probably mark it as GIST, okay. So then you have your interstitial cells of Kyle, which will be the origin. As we all know, the common GIST happens in the stomach, but it can happen anywhere along the, GIT. It is also known as EGIST, extragastric gastrointestinal stromal tumor, or EGIST. It is what is known as. Now, what is the IHC? Classically, CD117 and DOG1 are positive. CD34 will also be positive, like the interstitial cells of Kyle. Now, how do you identify? Mostly by the CKIT mutation in 70% of cases. PDGFR alpha will happen in around 7 patients. If both are negative, then SDH mutations can also happen. There are then a host of other mutations which are associated with the various syndromes like KRAS, BRAF, neurofibromatosis, all these which are associated with the genetic syndromes like neurofibromas, germline SDH. This is very, very common in multifocal GIST. Then you have your Carney-Strategy syndrome and the von Hippel-Lindau syndrome. All these are associated with your GIST. Now, the best prognosis is, of course, the gastric GIST, then the small bowel, and finally the colorectal. The order comes from top down, basically, from stomach to intestine to large bowel. That is how is the order. The best is in the gastric, and then you're getting the other subtypes. Now, there are various grading systems which are associated with this. all of these in some way or the other are based on three factors: the site of the tumor, the number of mitosis, and the size of the lesion. So in general, as we all know, that gastric cysts will have a better prognosis greater than jejunal. The next thing you look for is a size cutoff, which is usually, less than or equal to 2 centimeters, and then you have less than or equal to 5 centimeter, and then more than that. That is how it will work. 5 to 10, more than 10, like that it will go. Then you look at the number of mitosis. Basically, mitosis are a relatively less used thing, but then you look at the that aspect. So mitosis, Ki67, all these will be used. And so the criteria which are used, the NIH criteria is one, the Johansson criteria is another. They may ask you the names of the criteria. Each of these criteria are subtly different, but by and large, they give you based on these three factors: the size, the site, and the mitosis that will be there. There is a tabular column coming up in the next place. Now, management is for almost all, just except for a very small subset of gastric cysts. Everything else will need treatment with imatinib. Now, common is going to be your exon 11 mutation. When you look at the mutations commonly, you just rub off all this. Yeah. So now when we talk about the mutations, the most common mutation, KIT mutation, is found in the exon 11. Now this will be generally sensitive to imatinib. When you have exon 13, this will have an increased susceptibility to imatinib. They have a very good response to imatinib. On the other hand, when you have an exon 9 mutation, this will be less sensitive. And this is commonly found in bowel and basically small bowel and large bowel cysts. So this one will require a higher dose of imatinib. The standard dose of imatinib is going to be 400 milligrams daily. Now, in this, you may need to go to 600 to 800 or 400 BD, like that. You may need to go for a higher dose whenever you have an exon 9 mutation. And whenever you have a patient who has got an imatinib resistance in GIST, or you have the PDGFR D842 mutations, currently, previously the drug of choice used to be dasatinib. Even now in Sabistan, it's given only as dasatinib. But remember, if the choice is mentioned as avapritinib, especially for the D842 mutation, PDGFRs, whenever they mention, currently the drug of choice is avapritinib. So look at the choices. If avapritinib is mentioned, that will be the drug of choice. If it is not mentioned, then you can choose dasatinib. So when you have this mutation, number one choice is avapritinib, second will be dasatinib, and third one will be imatinib. Okay, so that is the order you have to mark it. Avapritinib is the first choice, second is dasatinib, and then you will go for imatinib as only the third choice. And if you look at the criteria, so these are the size criteria that will be taken into account here. As I already said, you look at the size of the tumor. So less than or equal to 2, 2 to 5, 5 to 10, and more than 10. And again, mitosis is less than 5, more than 5. And then if you look at the risk of progression, generally speaking, if the tumor is less than 5 centimeters, up to 5 centimeters, even for that, even less than 2 centimeters, there is almost a 0% chance of progression, especially if the mitosis is also low. When it is up to 5 centimeters, still the mitotic rate is low, still it is low as far as the gastric is concerned. But from this word on, in the small bowel and everything, the thing starts to increase. So mitosis and size, both of them have an important implication in prognosis, but especially first is probably more is mitosis, then it will be the size, and then it will come uniformly. So anything beyond the 5 centimeter size and greater than 5 mitosis, whenever you have, then the risk is going to be pretty high in all the subsites. Still, overall, gastric and this one, when you look at it, the chance is more with the gastric origin. Sorry, it's less with the gastric origin. The response is much better with the gastric origin tumor. Small bowel overall will have a poor prognosis. So this is the non-gastric. What is the staging which will be used, and this is the gastric staging which will be used. Essentially, both of them will be similar. Only thing is you will have a stage correlation which will be slightly different. T4 will come in stage 2, whereas no, it is pretty much the same. So whenever we have the treatment for a gastric cyst, the tumor is going to have a better prognosis overall, and imatinib will be the treatment. Whenever we have D842V mutations that will happen, or you have mutations in PDGFR or imatinib resistance, that the drug of choice will be avapritinib or it will be your dasatinib. Those are the two drugs that will be used in such scenarios. Then going on to the management of advanced soft tissue sarcomas, lung is the most common metastasis. When we look at the site of origin, most of these tumors will be present in So when you look at the site of origin, most of them will be in the extremities. So lung metastases are going to be the most common location of the tumor. Now, management can be done in many cases by lung metastasectomy. Provided the tumors are resectable, first option is to go for lung metastasectomy. Later on, you will add on chemotherapy. Some of the tumors which are sensitive, especially are synovial and angiosarcomas, usually it is a doxorubicin-based chemotherapy which will be given. Ifosfamide is another drug which is sensitive. Neoadjuvant chemotherapy can be tried in large extremity sarcomas also. Now, as I already told you, Ewing sarcoma, osteosarcoma, all these are highly chemosensitive. And again, when you have the round cell or pleomorphic types, and then you have the embryonal subtypes of sarcomas, the embryonal types. Okay, so the embryonal RMS or any kind of embryonal sarcoma, when you have all of these are sensitive to chemotherapy. So generally, in such cases, you have to plan for neoadjuvant chemotherapy first. In all other cases, it will be adjuvant selectively, which will be used. Now, some agents which can be asked are, one is the minor DNA groove inhibitor known as trabectedin, and TKIs, especially pazopanib is one drug which will be used quite a lot. Now, these are some of the advanced therapies that are available in soft tissue sarcomas. So I will close the session today with this. Sorry, I got delayed today as well. It has been a crazy, this one, elections and traffic and everything. So today's session, I'll close with this. Kindly put up your questions in the group with regard to any doubts you have with regard to the management of soft tissue sarcomas. Tomorrow's class is tentatively for 8 o'clock at night. We'll finish definitely bone tumors and if possible, start off the other things as well. So tomorrow's class is scheduled for it. If there is any change in schedule, Rahul will be informing you. So thank you, my friends. And again, sorry for the delay in starting the class. Okay. Thank you.